So we're going to start our panel discussion. I'd ask Dr. Brendan Murphy, Dr. Pat O'Neill, Dr. Niamh Lynch and Oisín McConville to come up and join us, please. Oisín, I might start with you actually, if you want to take the microphone there. You've been involved as a mentor of teams recently, obviously a long glittering career as a player as well. What have you noticed in terms of the shift, in terms of the culture when it comes to somebody getting a concussion or a suspected concussion and their willingness to identify, look, I think I might have an issue here? Have we reached that point yet where people put their hands up?
I think we're getting there. I think there has been a shift. I think as you go up towards elite level, I think players are more cognizant of it. I think as you go down to the level that I suppose I'm coaching at the minute, whether that be colleges or senior level or underage, I think the tendency is to dust yourself off and get on with it, and it's just changing that around, and it's just really educating people. And one of the interesting things I've picked up today is that the quicker you come out, the more chance you have to get back playing, quicker. And I think if players hear that sort of thing, then the chances are that we can turn these things around. If you with the GAA in particular, probably 80-90% of the football or the hurling that's played is played with probably zero physio, or maybe somebody just doing a little bit of first aid, no doctor in attendance, and maybe just one referee. And I think what I have noticed over this past while, especially at college level, is that the better the referees we have, or the referees with more experience, have stepped in at different times and been able to use their experience as far as what they've learned, I suppose, at a slightly higher level, and they've insisted that players are taken out of action. And I think the good coaches as well, if in doubt, will take them out.
Yeah. Pat, what's your experience of this, and where do we need to get to? I guess it's right to focus really on the GAA, given that we're here in Croke Park. Is there a case maybe for interchangeability in terms of, you have a set number of players and they can come on and go off? Sometimes you get the impression that a concussion happens in the last 10 minutes of a game and, go up there and stand in corner forward, as opposed to off you come because we've used all our subs. How do we just get that into the culture?
Well, I think you have pretty well stated it there, that can become an issue, particularly as Oisín has alluded to, in games where there's actually no medical or allied medical or healthcare input into them. So you're dependent on somebody that might have no either any form of medical or first aid knowledge making the decision. But I think the message has to come down really from through the whole pathway, that if there is a suspected concussion, that we take them off, and that is the policy that the GAA have followed. There is this attitude, I'd say, and it's probably because people are trying to keep players in sport, and of a head injury assessment for a period of time, with a view to doing an assessment and then putting them back in. Certainly at the GAA, and certainly in the medical aspect and the medical scientific welfare, that we have not adopted that situation. So the recommendation there is that if there has been a suspected head injury, that they're taken off, and that gives the window, and that they don't return that day, and that it gives the window where you can then proceed to an assessment in the immediate phase and in the intermediate phase that follows after that, and that's the policy as it exists. Going back to your question about a rolling substitute, that is under consideration by the GAA Medical Scientific Welfare Committee, and there's a meeting now to be formulated with the GAA doctors, which is coming up in the next by the end of this month. So to see if rather than a head injury or a concussion sub, that it can be rolled into maybe an injury sub, because there are other injuries that in the heat of battle that it is very difficult to assess on the field and even on the sideline, and that there may need to be a foreman and that you can rotate it so that it be a multi-purpose. So that is something that has been seriously considered.
You get the impression that the concussion sub would work really well in an All-Ireland final when there's 80,000 people watching and the medical staffs are huge, but junior football, the concussion sub could end up being something that becomes difficult to administer. Whereas if you do have rolling subs, then somebody who has a sore head goes, look, I've got a sore head, there's somebody there to come on.
I mean, that's the ideal situation, but one of the difficulties is that it can be abused. It can be abused strategically and tactically, and that is an issue. And we've actually seen that in the blood substitutes in Gaelic games and in other sports as well, where it's abused. So it's to get the balance here, but at the same time to have I mean, the main protection here is, one, to protect the player, and also to protect the people that are making the decisions.
Yeah, of course, because ultimately everybody has a shared responsibility there. Brendan, could I just talk to you really, the two sides of this? Again, somebody who has had an inter-county hurling career and is now involved at the elite level with the Tipperary hurlers. Seamus Callanan was here last year and told us his story about being concussed and just how ultimately somebody did actually have to say to him, listen, you might be suffering from concussion here. So, and he ends up having quite a long period out of the game to recover from that. So this is an ongoing thing. This cultural change is going to take a significant period of time, really, before everybody fully understands exactly what we're talking about.
Yeah, I suppose from my own point of view, I can maybe give an example of when I was playing versus, I suppose, what's happening now. I had quite a few concussions during my career, but maybe two kind of stand out. In 2004, week before we played the Leinster final, it was against Wexford. The 1 year Kilkenny weren't in it, I'd say. And there was a chance to win it, obviously. And Sunday before, fairly heated training session, Tullamore, there's a guy who's played full back for Africa, Ger Oakley, big man, Ger Oaktree we used to call him. But he basically annihilated me with a tackle, fair tackle according to Ger anyway. But what happened then was I obviously played on, but the next ball I hit it 60 yards in the wrong direction. And I remember the coach, Mike Mack, said, Murphy, what the fuck are you doing? Like, do you know? And then someone said, I think there's something wrong with him. So I ended up in A&E that day. But I suppose the point I'm trying to get to is that I was back out training the following Tuesday, the following Thursday, and played the Leinster final. Then on the Sunday, there was never a question that I was going to be stood down, or there was going to be a return to play protocol, etc. It was just, and that was maybe 2004. So the point I'm getting at is that we certainly have come a long way to now having this here today and having these discussions. And I know Mickey mentioned, and he's probably throwing the cat among the pigeons in terms of our return to play protocols, but it's there, and we now have advice we can give to players, and there is a protocol to follow. So that's massive in the space of 13 years that we've come that far, and now people are aware of the risks associated with these head injuries and these recurrent head injuries. And so definitely from a playing career to practice in medicine now, we have come a long way, yeah.
Niamh, you work in the paediatric side, and again, I guess one of the cases there it's not clear to a child the first time they suffer this exactly what's happening to them, because it's not a cut. They can't point at the blood and go, I'm bleeding.
Yeah, can you hear me?
Yeah.
So very often, obviously, a child doesn't know that they're concussed. Probably the best person to make that judgment is their parents, because they know them best. It's an invisible injury. So, unless you know what you're looking for. And now that I've been trained in the UPMC way, it's no longer invisible, it's been unmasked, because I know what to look for. But, that's the whole thing about this symposium, is to teach people that there are ways that you can diagnose concussion and diagnose the specific types of concussion. But for example, a Saturday match with 10-year-olds playing, if you as a parent or as a friend or as a coach are standing on the sideline and you see them take a blow or a hit, and you have that sense that something is not quite right, then you should speak up. And that's what the title is, make the call, don't be quiet. And you will actually probably redirect the course of that child's injury and recovery.
Mickey, it's a double-edged sword. These conversations are hugely important, because we've got this culture shift from, you go back out there and slap them on the ass and off you go, to the point where it's panicked and people take their kids out of sports because of the danger of concussion. So we need to tread that fine educational line where you are giving people the information and you're also encouraging them that the benefits of sport far outweigh the risk of being concussed.
Yeah, and I think I started doing this in the late 1990s, and I had to argue with parents sometimes in a very significant way to keep kids out of play, and now I'm arguing with parents to put them back to play. And the pendulum has swung from one side to the other. The truth is squarely in between. You know, there can be consequences of mismanaging this injury, and it can result in significant morbidity for kids. But until I'm proven, I think this is a highly treatable injury. We've made incredible advances as to how to recognize what's happening and target the right treatment for it. And I think sports is one of the most wonderful things kids can do. It develops them in so many ways. And I think that if, you know, awareness with no solution is called hysteria. Awareness with a solution is called, you know, good clinical management. I think that's where we need to shift the conversation to. You know, I really think we need to shift this to treatment, shift this to educating people that we can recognize and treat it. I think if you do that, you're going to get kids off the pitch in the right way. That kid that we treated, he came out of play on his own the second time because he knew we had treatments for it. And I think that if kids knew that, I think we could circumvent a lot of poor outcomes by getting kids off the field and getting them managed the right way.
Niamh, it was interesting that the incident in the earlier example that you guys were involved with, the incident had happened in the schoolyard in November, but he doesn't come to you until March. So that's 5 months of the wrong course of action being taken. Obviously, if you can telescope that time in future, that's kind of the benefit of days like today, I suspect.
Absolutely. I'm going to present some data later on about that. But, you know, it's events like this that help to get the word out that there are treatment strategies, and the more people know that, the quicker children will get treated, and adults as well, obviously.
Brendan, what's the level of awareness amongst the inter-county player now? Like, is it a topic of conversation? Or would they tell you if they were, you know, like, is it that kind of, or are they concerned about their place in the team to the point where they're trying to hide it? What's that experience like?
Well, I suppose I've been with the lads now 3 years. Certainly, after the first year, I kind of sat down and there was maybe a few instances that we probably didn't manage as well as we could, purely because you're going onto the field, you're trying to examine the player, and the player's telling you where to go, they want to get on with the game, etc., etc. But a few things have changed. I think the big thing, as you said, is education. So if you can, so at the start of last year and the start of the year before, I sat down at the start of the year, we did a presentation on concussion, what's going to happen if a guy gets a decent head injury during the game, how it's going to work. They have to answer the questions, they have to take a quick clinical examination, etc. And if there's a problem, they're coming out, and that's just the way it is. And thankfully, you know, the management team, Mick Ryan, etc., they buy into it and they get it. You know, I think, like Oisin mentioned earlier, I think the issue isn't really at inter-county or elite level. I think it's that public conversation needs to be had, and that educational process needs to be had with, you know, your junior C, B, A hurlers, your, you know, underage hurlers and coaches in particular. Because if the coach doesn't buy into it, they can put a massive amount of pressure on whatever healthcare professional is involved in the team, you know, about, look, this guy can't be coming off, etc. Yeah. So everybody needs to be on board with it, you know, not just the players, not just the medics.
Yeah, any questions out there, just stick your hands up. It does seem that maybe the best way to create that change is for it to be seen on TV in the big games, so that then it becomes a topic of conversation. That's one way of doing it. The other way is obviously education in every club, but then somebody has to have the responsibility, and it's somebody's job to go in and tell the team manager that before a championship match somebody can't play because they had a knock in training 3 days before, and that's tricky at club level.
Yeah, it certainly is, but again, it comes down to the fact that if you can educate them, we're looking at the bigger picture here, not the short term, you know. So and that it is like if a guy rolls his ankle, you know, there's no issue. Oh, he's out for a week to 2 weeks, no problem. Just that's it. But because for whatever reason there's no blood or whatever you mentioned earlier, it's a brain injury. Yeah. You know what I mean? So there's no question marks asked when a guy rolls his ankle. You know, it's okay. Well, he's missing Sunday, and so be it. But as you said again, but that just comes down to education, and we just have to hammer home the message, and eventually hope it sinks in. You know,
it is a very macho environment, yet, Oisin, at the same time. You know, like the whole notion of being able to play through injury. In whatever sport it is, a star player goes down, he gets treatment, the magic sponge, whatever, he gets back up, the crowd goes wild. You know, it's part of our sports culture that we really need to somehow stop.
It is, and you know, it's great sitting up here and you know, to say that, you know, if that player, I don't care who the player is, we'll get him out of there, and yet you find yourself on the sideline, you've got a moral dilemma as, you know, this guy's worth 1/6 to me. You know, am I gonna take him out? And that's the thinking that has to change, and that's the thinking that I suppose through a little education that I've had to change, and that if there is somebody within your club or within the college or whatever, and it only takes one or two people to sort of set the standard for everybody else around, and I think that's one of the things that that is going to make a huge amount of difference. And I think, you know, for the people that hear, you know, we have a clear message. And again, to go back to playing at elite level, when you're playing at elite level, there is no question marks around it anymore, I don't think. I think we pretty much have it nailed. And again, just the worry that I have is that the further we go down back into the, even just in particular the underage stuff, because guys at 14 and 15 are bigger than they've ever been, they're stronger than they've ever been, the hits are harder than they've been, and it's just a case of managing around that.
Where's the microphone? Sorry. Yeah, please get it back there. Yeah, the last one. There's 1, 2, 3 here. Yeah.
Thanks very much, guys. My question is specifically for Dr. Collins and the doctors. You can have players that will pass our Maddox questions and deny any symptoms on field. Given the fact that we've heard so much about visual and balance symptoms, are there any specific tests on field that might optimize our exam and enhance detection rates?
Yeah, the on-field tests that we have are, the SCAT, for example, does not look at the oculomotor system the way we do, and it doesn't really look at anything to do with the vestibular system other than the vestibulospinal pathway, which is balance. And some of these tests that are employed are not going to yield the sensitivity that we need to yield on the sideline all the time. You know, they're effective in some cases and not effective in others. I think even today's lecture, where we start to talk about the injury in different ways, gives you as a clinician a lot more information as to what questions to ask and how to look at these patients. And I also think the VOMS is a test that we need to continually evolve our research, and we need to do a very good sideline study on that test. We do the VOMS ourselves acutely, and so that is a test that can help guide you as well. But to your point, I mean, we don't really have, the Maddox questions aren't going to be very effective, and some aspects of the SCAT are not going to be very effective. So it's not like we have a blood test right now. And it's about understanding and trying to do the best we can. And there's no easy answers sometimes. But I'd like to make sure we reinforce, though, look, if there's symptoms of concussion that clearly occur after a blow to the head, the test doesn't matter. It's immaterial. The patient's out of play. And I think we have to be very careful with that and make sure that any suspicion of concussion, and that patient is removed from play, period. And that needs to be a very important part of our evaluation as well.
Yeah, not the case in rugby, obviously, at the minute. Go on ahead, Jack.
And David Galway, I was speaking with you at lunchtime there, Mickey, and you said to maybe if I wouldn't mind sharing my experience with the system. I've been using it now since last year's meeting, and I suppose on my behalf, I'd like to thank the GA and the UPMC for bringing this to my attention, because it's a fantastic system. It's completely changed my management of concussion to the better. And my experience, I suppose, during the year, it allowed me to make objective decisions with our inter-county team to a player who felt subjectively he wanted to go back. He felt fine, his testing was fine, but we had a baseline on him. I was able to retest him and tell him, look, there's the figures, you're not going back yet. So while that might have been a struggle initially to convince him, a few weeks later he's turned around, he's back, he's playing, and he's returned to his baseline, and he does thank you for making the right decision for him. My other experience of it, using Impact and the VOMS screen, is that it has revolutionized, in my opinion, the way we can now diagnose whether it's vestibular or oculomotor and target that treatment. The barriers I'm still facing, unfortunately, and I suppose it's an observation for any of the therapists or physiotherapists in the room, is that getting access to rehabilitate that player then, now that he has vestibular issues. And it's quite piecemeal in my experience, in that I've been making phone calls looking for physiotherapists who might say work in a ENT clinic, and if I have a vestibular concussion, they'll sometimes reluctantly see him, and I've had patients that have done quite well with it, but then the overlap, then am I looking for therapist that works in an eye clinic to rehabilitate the oculomotor side, and I've used Dr. Neve's system in Cork as well, which was fantastic for a young player who's just, say, within the cut-off age metrics. But I think more physiotherapists so that we can have that service for adults as well. And I don't know, maybe Niamh knows, or the Bonds system would know of other services that are going to be there, or other physiotherapists in the room to share if they are upskilled in that area, that we have a system to refer to.
I'd like to make three comments. First, thank you for your hard work with these kids, and the fact that you went and implemented some of the things we talked about last year and have learned so much from last year is what this is all about. Secondly, I want to thank the GAA for supporting this, because, I mean, just how many kids are you going to help? You know, quite a few, and that's very impressive work. Thirdly, I'd like to make a comment that this is just the beginning. You know, there's so much more to be done in terms of getting access for kids to have the right care. And there's some plans in the works to take this to the next level in terms of, I think workshops are needed. We can't, I gave a half an hour lecture this morning. I think it was more like 40 minutes, to be honest with you. I'm sorry for going over. But the point I'm making is that you can't teach this in that amount of time. We need to continue the education, continue the conversation, and make sure we're you know, the fact Niamh came over to Pittsburgh and spent the time she has, and you know, look at what it's doing in terms of clinical care, and we just need to build upon that, frankly. And there's a lot of smart people in this country. Getting everyone together and getting the sports medicine physicians and the physiotherapists together to come up with solutions is really the next step here.
You take adults as well, okay.
Yeah, so Aoife's just telling you there that we do see adults as well. And there are plans afoot to broaden up our coverage countrywide. Watch this space.
It seems like a growth area, unfortunately. Yeah, question here from the crowd.
Hi, I'm Navita. I'm a second-year medical student from the Royal College of Surgeons. So my question is, I'm involved with the Red Cross as a first responder. So in terms of going for duties on like sports events and then like rugby matches and things like that, is there a tool where you can identify concussion and then you can emphasize on advising them to go to a GP and then ask them for consultation after the event itself?
Well, there is. There's been. Well, there has been this international forum on concussion, and they have come out with guidelines, and there is a tool, the SCAT tool. Now, the difficulty with that is using it in the immediate situation, when there's the on-field or the sideline situation. But there is a tool, and I would refer you to that to identify, to possibly get the answer to your question. It does follow on then that there is a follow-on for the immediate. The immediate problem is one parameter of it. The next is probably the next 48 hours as to if there is a diagnosed concussion. And then the next is the actual return to play and what the interventional treatment that needs to be done. And this is where there has been a significant advance, as you've heard very much about today. But there is a tool there, and I would refer you to the international, despite some criticisms of it here today. But there is a consensus, but it doesn't reflect an absolute and definitive response.
Colin, yeah.
Yeah, thanks to the panel. I'm true to form. I'm going to interject a note of disharmony into the proceedings. So I'm just having a cognitive disconnect about something here. I've heard a lot of words hype and hysteria, and I'm not sure, does that relate to, am I speaking as a parent as well as a researcher, does that relate to discussions about CTE, which is this potential long-term consequence, or is it the fact that if we don't intervene with these kids early enough, then their return to play is longer than it might have been? Because the second one seems like that's really irrelevant to their long-term health. They go back to playing a bit later, okay, big deal. Because I would agree with Mickey, this is definitely a treatable condition in its acute form. Absolutely, no question. And I would totally agree, I can see that there's a conflict between what Berlin is saying, you know what I mean, and what you're saying. I'm completely on board. I work with Eugene Wallace in rehabilitation specialist in James's, and we don't rest anyone, right? But, you know, as a parent, and I'm asking the question of you is, what is your job to discuss CTE? What are you saying to people about CTE? And then I would ask you, as someone who may be invited, I don't know if you have been, but if you're invited to design public policy around CTE, what would you do now in terms of the regulatory environment? And if you can come back to me after when you get the response, Stuart, thanks.
Keep the mic.
My response is that we need to make policy based on science. And we need to make these very difficult decisions based upon science. And unfortunately, the science doesn't exist yet to guide us in terms of these issues. This is an evolving area. I feel that there is certainly concern about the potential for long-term effects, but we don't have well-controlled studies, 40-year, 50-year studies, prospective studies, understanding that concussion in and of itself is causing these problems, or is it other factors? And there's just not a lot of good data to help us make decisions on creating policies for kids at this point in time. And, you know, I heard you talk about the subthreshold issues earlier. Well, I can tell you the patients I'm treating not only have concussion, but they've had a lot of subthreshold events too, and we're seeing those kids get better and get back to play safely. And I'm worried that if we start making policy without having appropriate data, you can actually have deleterious effects from that policy. And so I just don't think we're at a point now where we can actually do that. And I think we need more research, and before we get out there and discuss it, globally, we have to have better research. And that research is being done, and I can tell you there's a lot of contradictory research on this topic. And there's a lot of interesting work going on, understanding what comorbidities may be involved, whether risk factors may be involved. There's clearly something wrong, but we don't understand if concussion is the only variable that's playing a role in some of these scary things that we're seeing.
Yeah, so thanks for that. I mean, I've heard that answer before in relation to this question. And the problem I have as someone who is involved at public policy level, you know, it's a bit like climate change. You know, the problem is when you're making public policy, you can't wait for the worst outcome. You have to make decisions that consider the worst outcome as possible. And unfortunately, doing nothing is just not an option. Saying that we have to wait for the research to be complete is just not going to happen. We're 20, 25 years away from knowing exactly what the risk factors for CTE are. And all of those people are coming up now. And I would agree with you, we have to move away from hysteria. For instance, I would not ever use that word in a talk of mine if I was in wide-ranging way talking about all aspects of concussion, including acutely. I wouldn't say that people are, you know, being hysterical about anything. The point is there's no room for hysteria, but we actually have to have a proper debate, and it needs to feed in to the discussion, because the only thing parents are worried about, is not Johnny going back late to play, or even that he doesn't, you know, get drafted into a professional team. They're worried about the long-term consequences. That's the only thing they're worried about. And you don't have symptoms. You don't have symptoms of that. You're not going to get symptoms of that for 20 years. So it's not a question of saying, oh, look, these guys have had sub-threshold blows and they're going to be fine. You know, they're fine, they go back to play. That's not the point. The point is maybe the sub-threshold blows and maybe the multiple concussions are going to cause problems in 25 years. And I don't know the answer to this, Mickey. I don't know the answer. I want to know what's the question. What is the public policy implications for that? And I know that we are not facing them.
No, and boy, that sounded pretty scary hearing what you just said. I'm a little anxious. And the reality is I don't know how many patients I've treated where they are scared and anxious, and it results in a lot of morbidity, and in fact, even suicidality in patients, when in fact, if you treat their anxiety and depression, the patient gets completely better and gets back to normal life. And so I'm just very mindful of having a conversation that's balanced on this topic. And I think the balance has to be that we don't have the answers of what the potential long-term effects are. What we do know, and I do take issue with the fact that when you say nothing's being done, there is a lot being done in terms of the 15 years or 20 years of work that's been done to have that lecture today and say, we're figuring out these different types of problems from concussion. We're actually coming up with active treatments for it. Do we have all the answers? No. But I think it needs to be a very balanced conversation. And I just think we got to be careful of how much fear is being risen in the public because of this issue, because there's a lot of, sub-threshold injury, it doesn't set in for 20 years. Those statements have power behind them, and I'm not necessarily sure we have the science to state that happens definitively in these cases.
If you need to go, okay. Yeah, we've got time for about 3 or 4 more here. So, yeah. Go on, yeah. Yeah, go on.
Yeah, sorry. My name is Liam. I come from a number of different backgrounds. First and foremost, I'm a player who's played the game for the last 25 years. I'm also a physiotherapist working within the HSC and an inter-county setup as well. Thanks very much for this day, and I was here last year as well, and similar to the Galway team doctor, we brought back an awful lot into our own setup in terms of management and the rehabilitation of concussion. At an elite level, I can see the improvement in concussion management and treatment. But my worry is, as Oisín was saying, was in the lower grades. I'll take it back to 2016. I was playing a Division 3 league game in the back end of Atboy on a cold, wet night when my own brother made a diving block, received an injury to the head. I went out on the pitch and I asked him the Maddox score questions. Sometimes I also am the goalkeeper / physiotherapist in these sort of league games. In the second half, he went on. He had the best game of the season, man of the match. And on the way home, I told my nagging mother to stop annoying us, that he was fine. But I looked back and he was wearing his own jersey. Now we got home, he called, I could just hear him shouting from the bathroom that he was vomiting and to call Mam. So what happened, I sent him into our local hospital in Our Lady of Lourdes, where I'm actually working now at the minute. And that was real reassurance for me that I knew he'd be managed quite well there. When he was admitted, he was kept overnight, administered IV fluids, and sent home the next day. He asked about when he could go back and play, and he was told, look, when you feel right, a couple of days, give it. And I suppose I attended last year, and one point that really stuck with me, that there was actually no formal ED training in the concussion management or training. I suppose if Oisín there, if a player gets a knock to the head and he's a 14-year-old in Crossmaglen, most likely go to Daisy Hill Hospital. But if they're sent there and there's no training in these hospitals, that's my biggest concern. It's great to hear from Colin, I suppose, with the national insurance guidelines that are going to be set up. In my own hospital, I fed this information back to the hospital, and I met with the ED doctors, and they had told me that what to do is basically made up on the spot in terms of concussion management, that there was no set guidelines. And that's quite a scary thought, I suppose, for any parent, player of an awful lot of team doctors. At an elite level, it seems to be working quite well, but it's my worry is, where do we send them? Similar, I know we've just set up now in Cork, but when will the guidelines be set up? I suppose Colin as well.
Brendan or Pat, do you want to talk about that, or Colin?
Yeah, well, I don't mind having a stab at it. Well, I suppose, again, it's about making a diagnosis, and thankfully there is a lot of information there. In fairness to the GA, there's some really good stuff on their website about where to go and what to do. Generally, I suppose I can only speak from my own personal point of view. If we have someone coming back into the graduate return to play protocol or whatever it is, and it's not working out, they head for neurology. Now, I suppose this is an ongoing thing, and it sounds now, obviously, what's going on here, traditionally what we were doing maybe in terms of rehab hasn't been as effective as it should have been. So it's good to see now there are specialist clinics popping up, and just as Gerard said earlier, it's going to be a growing area. So I suppose it's going to be a case of watch the space by the sounds of it, and that's where we're going to have to go in terms of team management. But I get your point. Again, it comes back to what the very first point we made. At elite level, I think we're doing okay here. But I think it's just filtering that message down to the lower levels of the game and just keep driving home that message. And hopefully the more people we educate, and then more people know how best to manage these individuals.
Yeah, it seems like the continuous personal development or professional development of the ED departments and doctors is something that has to happen at the same time as what's happening with the sports organisations. There's a question just in front of you there as well, yeah, Katie?
Thanks, sure. Can I pick up on Colin's theme just a little bit to add to this harmony? Mickey, I was really interested in what you said about awareness without a solution is hysteria. And the solution we seem to be proposing today is education. And I'm going to say from my area of expertise, which is culture, that awareness without understanding culture is silly. And I want to give a very simple example just to try and provoke it a little bit further. And there isn't an easy solution, but I want to try and tease it out a little bit. We see people walking into a shop every day buying a cardboard box that says, if you take this, it will kill you. And they do it. Now that's education. And awareness of culture needs to be taken further in the context of sport. So I'm going to suggest today that whilst concussion and mild traumatic brain injury, the variations of it is obviously very serious in biomedical terms, as equally serious are the social sciences. So in our public debate, we need to have social scientists. And I'm not trying to sell my expertise, I'm saying it from the perspective of what I'm trying to do. Let me give you a practical example. We're involved in research and concussion in rugby at non-elite level, and I don't think we've solved it at elite level, Brendan. I think we're on the way, but we've far more to do. If we send mixed messages to our players that actually of all the injuries these days now, concussion's the most important one, and therefore you should look after this, they're entirely confused. So on the one hand, I should walk off the field of play if I don't feel right, but on the other hand, I should stay on if my arm's falling off, just to oversimplify it. So I think we need the social scientists in on this debate. I think we need to think more carefully about differentiated health messages. That's as equally important as understanding the trajectory, the epidemiology, and the management of concussion.
Okay.
Can I just say, well, first of all, thanks for your comments. Second of all, it's much more important to play sport than to avoid sport. And thirdly, most of the concussions that I see, or many of them, have had nothing to do with sport. And so, you know, we need to open up the discussion about concussion to much more than just sport.
And I'd like the conversation to start shifting to the fact that we do have things that can be done to help with concussion. And that's what I mean by awareness with no solution. I mean, if we can change the conversation to the point of and be able to share with the parent, yeah, the concussion can be pretty significant. There can be a lot of problems from that. There's no question. But we can change the conversation to, well, with something we can do about it and treat it. I definitely think that changes the discourse. And I couldn't agree more with your point. There's a lot of societal implications here, and I agree with Neve's point that sports are a wonderful thing, and I also agree with your point, Colin, is the fact we don't have the answers here, and these are difficult questions to address, and but I do feel that we can't make sweeping decisions at this point without having that decision, because there's a lot of harm that can come from that. If we tell kids they can't hit a soccer ball and they don't know how to, I'll tell you, the worst day of the year for me in clinic is the first day of football season, which is August 12th, okay? That's when contact starts in this country, in the United States. And kids that have never played football before go out there and don't know how to tackle and get hit. Those are the worst outcomes we see all year. And it's because they weren't educated on how to tackle properly. And so if we take that away from kids and teaching them how to do it properly, we could end up with much worse outcomes down the road. And so I just think that before we make those decisions, we better have good data to help support those decisions.
But just for example, as a public statement, would you agree that if you remove the helmets from American football, you would make it a safer game immediately? And if you agree with that, why wouldn't you call for that?
I don't.
You don't agree with that?
Do I think it would help? I don't know if it would or not. I'd like a nice prospective study on that, because we're talking kind of about rugby in that situation. And if we compare the incidence level of concussion in rugby and football, we may have fewer incidences in rugby, but they may be more severe. And yeah, taking the helmet off of the player, would it protect them from using their head as a weapon? No question. We see that happen all the time. But there could be unintended consequences there, and I'm sure there would be. I just think that's a little extreme at this point to recommend that before we have better answers.
Yeah. Time for one more after this.
I'd just like to ask the panel from a GAA perspective, and what the Galway doctor said from the talk last year, how do you feel about the baseline testing for GAA players at the elite level, even as a starting point?
As in, should everybody be tested?
Yes, if you're working with a county panel, would you do baseline testing? And what baseline testing would you do, or would you recommend?
Brendan, since you do actually work with an inter-county panel, do you do baseline testing on every single individual?
I don't, I'll be honest. I should, and I will. Normally what I do is, if when they come in for their pre-season medical or whatever, if they have a history, I have done it in players who have a history of previous concussions to have it documented, and but not. So at the start of the year, it could be 40, 45 lads coming in at the start of the panel. I don't know, maybe they're not 30, maybe. But
and strictly after January 1st.
Exactly, yeah. So, like obviously, I don't, but maybe I should, and maybe that's something we should start doing. I think we will start doing it, and look at this. Is what days like today are about learning. I'm not saying. I know that lady questioned me. I'm not saying. I said we did okay. By the way, I didn't elite level. I don't think we're far from where we want to be. I just say we're doing okay, and we're all learning all the time and trying to improve things. So, but I think you're right. We should probably, as a baseline, everybody should have a baseline score done, and that's something I'm going to bring into my practice. Yeah.
There's a microphone there. Yeah, you've got.
Yeah. Hi. Sorry. My name's Aisling Freer. I'm a physio and a player as well. So I just kind of wanted to. There is a question at the end of it, but it's just to share my experience as well with it. Last October, I was at the concussion conference here, and last March I was actually playing junior football match, and got a concussion myself. Completely confused, didn't know where I was, didn't realise I had gotten a knock to the head, and the automatic reaction was put me in full back, to be perfectly honest, because I was so confused. Like, I mean, I think that's the GAA, you know, among players, and especially lower level, that's the way, you know, it has been for a while. So I decided to get myself checked out, went to the GP. My coach at the time was very, very good, immediately removed me from play, and the referee as well. So the club just handled it really well. Went to the GP and they did a SCAT form with me. Objectively, completely fine. Subjectively, 22 symptoms that came out from it. So I was told to rest, had to take a few days off work. Long story short, the rest didn't work. I was dying to get back to football as well and get back to work. So decided to go back to the gym, tried to follow the IRB protocol, was getting dizzy on the treadmill, all that kind of stuff. And it was only for that I went to a physio myself that worked in the practice with me, that was specialising in vestibular rehab, that she kind of did the VOMs and that kind of stuff with me. And I thought, this is so simple, like this, there's no way it's going to work. And I was actually back within 5 days after being out for 6 weeks. So it's just to show that, I suppose, treatment and actually provoking it does help. But the question within it is, how far is the scale that you like provoke the symptoms to? Do you know? So I suppose with tendon issues, we would look at, I suppose, a 3 or 4 out of 10 pain sometimes to when we're exercising to provoke the symptoms. But I'm wondering, with concussion, is there any form of measurement? I know it's hard to.
It depends on the case. Your case is very cogent and it's impressive. I wonder if being here last year helped you understand maybe how to approach it.
100%.
I hope it did. That's pretty cool. Question for you: are you back playing now?
Yeah, I'm back playing.
That a girl. That's what I like to hear. And you feel fine. Everything's good.
Yeah, absolutely grand. I found specifically there was one drill that I just had such issue with, and it was coming up and down, and we were kind of doing a figure of 8 and just passing the ball around. But basically, it was because of that vestibular problem.
And you know, to answer your question very generally, yeah, and Anne, I think is probably better to answer that than me. But I would say we do provoke symptoms to about a 3 or 4 out of 10. Recover, and you should see the recovery times get better after those provocations, and that's probably how you felt like when you did the therapy. Your recovery times just improve, and then it takes more provocation to get to have symptoms, and that's when you know you're getting better. And it gives a very targeted way of treating it. But yeah, your case sounds pretty coherent as to how we approach our treatments.
The man in the back row has had his hand up for ages. I'll get you at the end
here. Hi, thanks again to the panel. And I was here last year, learned a lot last year, and an awful lot more to learn this year. I just have a comment maybe on the statistics that get brought up, and maybe there's some dangerous statements might get made about saying that the incidence of concussion is higher in women, or the incidence of concussion is higher in one sport compared to another. I think that a lot of the people that are getting treated for concussion or might come to the door of UPMC or Bon Secours, that's very dependent on somebody reporting, on the player making that call, a physio making that call, a parent or a doctor making that call. is there any studies out there that are, that are kind of free of this reporting, that you just measure every player every week? I'm not saying, of course, that's not practical for every player playing every sport, but maybe take the Penguins or the Steelers or an inter-county football team and measure them every single week, and maybe then, maybe the results are a little bit scary. Maybe there's more concussions, or maybe the symptoms are getting worse than we think. I just think it might, unless we have that completely full picture that we have a player taking themselves out or a player presenting with concussion, it's kind of dangerous to make statements that concussion is more, that happens more in one sport or another, or happens more in one demographic than another.
I wonder, is that the point of the Trinity College concussion research, that they are actually trying to take full teams and measure it across? But sorry, go on.
And that research does exist. There's been research done on those issues. Anthony, you want to speak to some of the research on this? But I know there's one study done, very well done study, where they looked at impact, for example, preseason, midseason, postseason, and did not find any differences across the football season in those not diagnosed with concussion. And there's other research studies, and Anthony, you can speak to them probably more clearly than I can, but there's some findings on either side of that aisle, and I want to make sure, Colin, you hear me say that your research is phenomenally important, and I hope it continues, because that's the type of work that needs to be done. And I respect that approach, and that's what has to occur, not just yours, but other folks. And Anthony, you want to speak to the research that's been done in that space?
Yeah, I do, now that you drew attention to me. So yeah, no, certainly. So it's important to note that, and this is a little American-centric, we have a large study that the NCAA, the National Collegiate Athletic Association, and the Department of Defense, which is interesting because they have a vested interest in brain injury as well, funded, that is doing just that. We're looking at 33,000 student athletes, so it'll be the largest. It's like the Framingham Heart Study of concussion, if you will, so it's kind of looking at it prospectively. And what we're doing in version 1.0, which just concluded, was 3 years. We retested them twice a year, not every week. There's an issue when you test too often because you have effects of testing. And also you're focusing on these symptoms all the time, which can have an adverse effect. But on the positive, we're getting data every 6 months. There's a second part of the study, it's referred to as the ARC, which is an advanced research core that looks at blood, genetics, saliva, imaging from DTI, high definition fiber tracking, as well as blood, PET, and other scanning. And that's being done with about 600 athletes. And these are being done over the course of 3 years, but we just got re-upped for another 3 years, and then there will be an every 5-year follow-up longitudinally. So that'll allow data that have already started to be collected to answer some of these really challenging questions that were pointed out earlier about what are the actual prospective long-term effects when we look at risk factors, concussion exposure, football versus soccer, men versus women, et cetera. And hopefully over the next 3 to 10 years, we'll have some better answers for that.
And knowing that, Anthony, really reinforces what I'm trying to convey to you is the fact that we need good data to help answer these questions, and that data is forthcoming. There's some very powerful work being done that's going to help to answer those questions. And I just think that before we make huge policy change, I think having those studies to reflect on will be a very important part of that.
Peter, I know you wanted to come in a little bit earlier on.
Thanks. Yeah, no, it was just a comment, really. I mean, I know the word hysteria has been mentioned and so forth. And I
may have chosen a different word if I thought it would have brought up all this
in
stuff,
retrospect.
Yeah, right.
The point I was trying to make is that, you know, I don't want to come across that the neurology world is scaremongering about this. I don't think any of us, you know, aren't aware of the absolute huge benefits of sport, or advocating that we start pulling every kid out of every contact sport. And clearly there are sports that are more at risk than others. But you know, you did make the point that there's very little data. But what data there is available does suggest that exposing the human brain to recurrent trauma from a young age over a long period of time is not good for it. And
Which I don't think is a big surprise.
Yeah.
It shouldn't be anyways.
And I think, you know, sometimes, you know, it can get lost a little bit in the debate about whether the trauma produces symptoms. We call that concussion. and whether it doesn't produce symptoms. There's still trauma, and particularly in sports concussion, obviously adrenaline is pumping. It's no surprise that that people don't necessarily get symptoms, because adrenaline, as we know, can have extraordinary pain-reducing effects, etc., etc. But there's still, a debate that needs to be had, and there's still a risk. People need to be aware of a risk that if you're dropping 7, 8, 9-year-olds off to a field and their heads are being hit repeatedly, that there's a risk associated with that, whether or not there's concussion or no concussion. I think there's a reason we've evolved to have a thick skull, around our brains, because they're vulnerable. And I think shaking them around over years and years and years, the evidence, although it's not, clear in terms of how much injury, what types of injury, who's more at risk, there are certainly things that need to be teased out over the years. But there is, I think, certainly a significant amount of evidence suggests that exposing the young brain to repeated injury is not good for it.
And I don't think that's a big surprise, and I don't disagree with you on that. What I do feel, however, is that making decisions, having science can be very helpful, and I'm all about taking violence out of the sport in terms of rule changes. There are coaches in the United States. You ever heard of an Oklahoma drill in football, where it's two kids ramming heads in a very, very aggressive way, and I've driven down the road and seen that going on, and it makes me sick to my stomach to see that. And we got to be aware, if we can take the head out of the sport, it's going to obviously prevent problems from happening. But there's a fine line there, and we don't live in a black and white world. And I'm all about rule changes. In fact, I've been involved in some of the rule changes that have occurred at the National Football League, where they've actually changed the rules around kickoffs in the NFL. And they found out in the NFL that most of the injuries, a lot of concussions were happening on the kickoffs. And so they've made changes, and that's improved those numbers. That's what I'm trying to relay, is the fact that if we can come up with science and lead our decisions on that, I think that's the better approach. I think we're all uncomfortable. We don't have all the answers right now, but that's science. And I just think we need to be balanced in how we approach this. I couldn't agree more with your points.
All right, that's the end of our panel discussion. It's been great. We'll continue that over lunch, no doubt. A big round of applause, please, for Oisin McConville, Niamh Lynch, Pat O'Neill, Mickey Collins and Brendan Murphy.